Urolithiasis is the formation of stone anywhere in the urinary tract, either in the kidney, ureters, bladder, and urethra. The prevalence of urinary stone in Asia is about 10 to 20%, and the peak incidence is at 30 to 50 years old. This is the third most common disease that presented to urology department, and male affected more than female. Next. Okay, so for the pathophysiology, there are two pathway for stone formation. Next. Okay, so for the supersaturation of the urine is the most important cause of stone formation. When there is a increase in urine concentration of stones constituent like uric acid, calcium, and oxalate, it will exceed the solubility in the urine and causes crystallization and and then crystal aggregation, and it may flow out with the urine, or some it will retain in the kidney and cause aggregation and uh, forming the stone. Okay, this usually occur in a patient with regular dehydration due to lack of fluid intake, or patient with or patient who have a higher level of this substance in their blood. For example, gout have increase in uric acid, and hyperparathyroidism for calcium. Uh, and then if they have higher level in the higher level of this substance in the blood, they will have a higher excretion into the urine. Next. Okay, so the next one is uh, recurrent urinary tract infection. When there is a recurrent infection, um, in for example, next lagi. Okay. For example, in Proteus vagularis infection, this organism is capable of splitting urea. So, the urea will split into ammonium, which generate alkaline urine. Alkaline urine is fiber precipitation of MAP, magnesium, ammonium, and phosphate. This is known as a struvite stone, and also known as infection stone. Okay. And other than recurrent urinary tract infection, also in when there is a obstruction of the urinary tract, for example, enlargement of prostate, cause a stagnation of urine, will also cause stone formation. Okay, I think that's all from me.
I not see the pathophysiology of urolithiasis in detail. The what we call the infective type and the supersaturation type. You have it? Okay, this is the infective side. Can you show that again? Okay. Uh, I not see the what we call two main what we call changes in this chart. One is the what we call inhibitor. Another one is promoter. Do you have put in up the main substance? But I think you need to know that this substance actually promoter. Promoter, it means it faster the process of supersaturation toward the stone formation. One is dehydration, two is uric acid, and three is calcium. Whereas you have inhibitor, which is reverse this process. It's include sorry. Another one is that is true. Citrate. You have also rehydration, and you have magnesium. So because this is chart is the most important chart in terms of chemolysis. How we chemolyze? We reduce uric acid by giving allopurinol. We ask the patient to increase the fluid intake, and we give a citrate to reverse the process of stone formation. That's what I not see. The inhibitor and promoter along this chart. Okay. The next thing, the infective stone. Have you put up the infective stone? Okay. This is a chart for infective stone. Okay. I maybe I not focus about this. I went to see the the type of organism we call urea splitting bacteria. Yeah, it is very low down. We not what we call not clearly seen in this chart. So okay, this is there in the chart. Because these two chart is very important. One is for the management, another one is for prevention. Let's say that you get a patient with a stone, you see urine culture, the culture shows presence of proteus, all this type of organism, you know that this patient have infective stone. So we need to make sure that patient always have clear urine from infection to prevent recurrent. Okay, I think that's all for a first presenter. We can proceed. Any other question?
Mr. I would like to ask,
Okay, proceed.
uh, can I ask?
Yeah, can.
Okay, you mentioned just now regarding the magnesium is the inhibitor, um,
Yeah,
but in struvite formation is a magnesium ammonium phosphate. So
yeah.
does the magnesium in that struvite stone give any like inhibitory mechanism?
Okay. The a lot of thing in stone formation actually still at the theory basis. Even in the model of supersaturation, yeah, magnesium is inhibitor, but nobody able to create the drug which based on magnesium yet. Because as you know, magnesium is 2 plus. You make a problem with neurotransmitter when you add in 2 plus magnesium into your serum. So same thing here is a complex process. For example, a calcium in the supersaturation is not pure calcium. It's a calcium metabolism involving the phosphate. So you cannot advise patient not to take a meal or any calcium sources because it's not that gut or blood calcium which we are talking here. We are talking about urinary or renal calcium. Same thing to magnesium ammonium phosphate. Actually, the bind or combine of magnesium to ammonium because magnesium is 2 plus and ammonium is negative. So that's why without ammonium, magnesium act as a inhibitor because it a competitor for calcium. You understand? It's 2 plus. Both is 2 plus. So it's a competitor to calcium. So it prevents stone formation because it may win part of the place. So calcium we have lack of in concentration inside the urine, inside the urinary tract. So that's why without ammonium, magnesium has a inhibitor ability because they are competitor to calcium. But with presence of another 2 plus, the combination of magnesium ammonium it form a different type of stone we call struvate. So as I mentioned, it's not fully proof. It's still theory part. But as I mentioned, if only cast magnesium present, it become an inhibitor because it become a competitor for calcium. But when present of another anion with negative, it will cause a formation of struvate because it combined with the negative ion to form the magnesium ammonium phosphate. That's what we know now, but nobody able to prove really in the what we call in real human being. It's just in a lab so far. It's clear.
Yes, thank you, Mr.
Okay. Okay, if no question, we go for next presenter.
Okay, Bismillah. Assalamualaikum warahmatullahi wabarakatuh. My name is Nohadini and I will cover the subtopic of type of stone, risk factor and clinical features of urolithiasis. Generally there are 5 types of stone. Stone made up of calcium, struvite or magnesium ammonium phosphate stone, uric acid stone, cystine stone and xanthine stone. Calcium stones, particularly calcium oxalate stones, are the most common type of stone. It has a picture of hempseed or mulberry or jack look like stone, and it is radiopaque due to high calcium content. Struvite stone, as mentioned before, it occurs due to chronic infection of urea splitting organism, typically present as large staghorn calculi, and it is poorly radio-opaque compared to the calcium stone. However, due to its large size, it can be easily detected on radiograph. We also have uric acid stone, constitute 8% of all stone. It is reddish brown in color and radiolucent. Cystine and xanthine stone are rare because these are stones that occurs mainly in rare inherited disorder. Cystine stone is radio-opaque due to presence of sulfur, while xanthine stone is radiolucent. So in the picture here, I want to highlight the features of the struvite stone. Struvite stone has a smooth surface, thus it rarely causes mechanical injury to the renal tract. So the patient usually asymptomatic and the stone can grow very big, filling the pelvic calyceus system, present as staghorn calculi. Meanwhile, compared to the calcium stone, it usually small. It has irregular surface, small, with sharp projection. Thus, patients with this stone are usually very symptomatic and it can pass to the ureter and cause renal colic and also injure the wall and cause hematuria. Okay, next we move on to the risk factor of urolithiasis. Among the risk factor are excessive urinary excretion of a stone constituent. This condition occurs in certain diseases or conditions such as hypoparathyroidism, in which there is increased calcium excretion, hyperoxaluria, condition that occur in inherited disorder, which lead to increased excretion of oxalate, gout, or chemotherapy, post-chemotherapy of blood malignancy, which lead to increased excretion of uric acid, cystinuria, a condition occur in also inherited disorder, which lead to increased secretion of cystinuria and also xanthinuria. Also, a condition occur in inherited disorder. Next is the idiopathic, meaning in idiopathic, the patient excrete excessive calcium in the urine without specific underlying abnormalities. This is also known as idiopathic hypercalciuria. So, it is the most common causes of urolithiasis. Next is urinary stasis. Urinary stasis, particularly as if it is associated with infection, it predisposes the patient to develop the stone. So urinary stasis occur in patients with congenital abnormalities such as horseshoe kidney, patient with hydronephrosis, or chronic obstruction such as benign prostatic hyperplasia and neurogenic bladder. Next, chronic urinary infection of urea splitting organism, foreign bodies such as fragments of fragments of catheter tube or parasite. This foreign body can act as a focus for the stone formation. That's also dietary, such as high calcium intake, which eventually lead to increased calcium excretion in the urine. Others are multifactorial, such as prolonged immobility, multiple fractures, and paralysis. These patients, they will have scattered decalcification because of the immobility. So there will be increase in calcium excretion. So let's move on to the clinical features of urolithiasis. The presentation depends on the size, morphology, and site of the stone. So the stones produce their effects in three main ways: by obstructing the urinary flow, either in the pelvic system, in the ureter, or the bladder neck. Second, by predisposing to infection. Third, by causing local tissue irritation. So, by obstructing the urinary flow, if the obstruction occur in the pelvic calyceal system, the patient presented with chronic or recurrent loin pain. If the obstruction occur in the ureter, there are two causes, either chronic or acute. In chronic, the obstruction is partial and presented as loin pain or asymptomatic. In acute obstruction, a patient will have ureteric colic, and ureteric colic because of the ureteric peristalsis to relieve the obstruction. In bladder neck obstruction, where if the stone able to pass urethra, enter the bladder, it can cause bladder neck obstruction, and this eventually patient will have a urinary retention. So by predisposing to infection, patient can be presented with acute pyelonephritis, perinephric abscess, cystitis, or ascending infection. By causing local tissue irritation, if the inflammation or irritation is simple, patient will be presented with hematuria. If there is chronic inflammation, patient will develop stricture. And if the chronic irritation occurs in the bladder, it will lead to squamous metaplasia and eventually squamous carcinoma. So as we know, the bladder normally, the normal bladder will have transitional epithelium. However, in chronic inflammation, it will changes to develop more durable epithelium, which is squamous, and eventually may lead to squamous carcinoma. So that is more specific. This is a general clinical features. Patient may be asymptomatic. If symptomatic, patient may have loin pain, particularly in chronic condition. If acute patient, it is usually a ureteric colic pain. How do we know it is a ureteric colic? The pain is characterized by sudden onset of severe and agonizing pain that develop from loin to groin and often associated with nausea and vomiting. Okay, so ureteric colic usually occur when the stone is impacted in the ureter. However, it can also occur when the stone is located in the pelvic-ureteric junction. So patients with ureteric colic pain almost always have hematuria. However, most of the cases of the hematuria is microscopic hematuria. Next, patient may have rigors, fevers, or lethargy. This indicates suggestive of infection. And patient may have passage of small stones or sandy urine. So particularly for bladder calculi, the symptoms is related to the posture. So when the patient stand, the patient will have stabbing pain and desire to micturate. This is because the bladder, as a patient stand, the stone will move to the bladder trigone in the neck. When the patient lie down, the symptom resolve because the stone roll back. into the other parts of the bladder. Patient may also have history of sudden cessation of urinary flow that is relieved by lying down, also due to the same mechanism I mentioned just now. So for the physical examination, usually it is unremarkable. However, patient with urinary colic pain, we can see that the patient is very in pain, breathing in pain. Patient may also have signs of dehydration because of vomiting, and also tenderness in the flank, meningitis or infection, acute pyelonephritis. Okay, basically that's all for me. Any question?
Okay, any question? Your management is not with you. They will later.
Management after that,
After that, okay, okay, never mind.
diagnosis and then management.
Okay, okay.
Okay.
So what other classical bladder stone have been described just now? Pain and suddenly you have no pain. What would they call that? Classical textbook call. You have been described properly, but I think you don't put in the term. The term.
Tak ingat lah Mister. Sorry.
You said that when the stone in the trigon, the pain is there, but when it moves to other place, it's the pain resolve or there are no more pain.
Yes.
Strangury. You just check strangury. 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 That's one. Another thing is classical referred pain. Classical referred pain. For example, a patient have renal pelvic stone. Where it referred? If you read textbook, you will find all this. But I think in the current, they not really like to describe because it's the classical is not mean common. It can be just 10% or 20% of patients presented with that, but it's classical have been described by textbook. One is strangury in the bladder stone. If patient have renal stone, if you read textbooks, they will describe the pain radiated to is loin to groin. Loin to groin. Yeah, it's radiated to groin. Whereas it's the urethric stone. Where is radiated? Urethric. So the pain will be in the groin because just now loin to groin, so it become further down. Groin to genitalia. We have to have patient come with what we call scrotal pain in male. And then up we noted patient have urethric stone. So the classical in textbooks they describe as strangury in the bladder stone, loin to groin in the renal stone, groin to genitalia, male or female, both will get the similar radiation in urethric stone. That's classical. Another thing is pain at the tip of penis in the bladder stone, also classical presentation of bladder stone. I forget to remind that in anatomy, at the near tip of penis, there is a dilated area there, but what we call, sometimes the stone can stuck there and patient presented with acute urinary retention, but it's not common.
Okay.
It's called navicularis fossa. At the gland penis in urethra, they call navicularis fossa there, where sometimes the stone stuck in that fossa and is developed and what we call it enlarged there because if there is space there, distal to that fossa is a strictured area. So all this classical, if you use a journal or internet as reference, I think it may be not use all these terms because it's not common. Like strangury is not common in bladder stone, but classical presentation. Okay, any other question? So if no question, we go to next presenter.
Yeah. Thank you, Mr.
Okay.
So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Ahmed and I'll continue with the diagnostic approach to urolithiasis. Next. Okay, before we go further, we need to know the objective of the investigation that we'll be doing. Okay, the first one is we want to confirm the presence of the stone. And next, we want to locate the position of the stone. And also, we want to evaluate and see if there's any effect of the stone on the renal function and the morphology of the urinary tract. And also, we want to identify if there's any structural disorder in the along the urinary tract that predispose to the stone formation. And finally, we want to check if there's any metabolic predisposing factors that cause urolithiasis. Next. Okay, the way we diagnose a stone, like my friend explained just now, first is based on the detailed history and physical examination. And next, usually we will do imaging to confirm the stone. And the common initial evaluation in patient that present with that we suspect with stone is ultrasound. Because ultrasound is safe, the results are reproducible and it is inexpensive. By doing ultrasound, we can detect presence of stones in the calyces, in pelvis, and in pyelourethric junction. And also we can see if there's any dilatation in the upper urinary tract. And some studies says that uh, renal ultrasound is equivalent with CT scan to diagnose patient with large kidney stone. Okay, next. Okay, so this is an example of the ultrasound. When we do ultrasound, this is the possible finding that we can see. Okay, I give you a situation. This one patient presented with the pain in the right lumbar region. So the doctor do ultrasound and they found out that there is a marked echogenic lesion in the lower calyx of the right kidney. And also there is acoustic shadowing posterior to the lesion. So based on this finding, we can diagnose presence of a renal calculus. And furthermore, we can measure the size of the calculus. In this case, it measures 15 times 10 millimeter. And we can also know the location of the stone, which is located in the lower calyx. And furthermore, the absence of pelvic calyceal dilatation is suggestive of no obstruction to the urinary flow. And some additional notes, it is always useful to scan the renal stone in two planes for a better and accurate measurement. Okay, next. The next commonly done imaging modalities is the kidney ureter bladder X-ray, or commonly known as KUB X-ray. This modality is commonly done because it is non-invasive and readily available. It is a plain X-ray, no contrast used. The patient need to be positioned in supine position during the procedure. And from this X-ray, we can visualize and locate calcification anywhere along the urinary tract, from the upper down to the lower. and usually the stone can be seen, and most of the time calcium stone will can be seen through the KUB X-ray, because like my friend explained, calcium stone are radio opaque. Okay, next. Okay, this is the classification of stone based on the opacity. As you can see, all calcium stone are radio opaque, and the non-calcium stone are either have poor radio opacity or radiolucent. Okay, next. Okay, this is an example of KUB X-ray. Okay, you guys see the X-ray and try to identify if there's any stone or abnormality. Okay, I give you time. Okay, time's up. Next. Okay, this is the stone. Okay, next. Okay, next. The diagnosis is Staghorn calculi in the left kidney. Okay, next. Okay, this is another example of KUB X-ray. Based on the finding in this X-ray is multiple stone. Usually, when we do KUB X-ray, the findings can be the stone may be single or multiple, and it can be located anywhere along the urinary tract, and the shape may varies. And sometimes, uh, even though your clinical diagnosis is urolithiasis, but when you do X-ray, you cannot find any stone. Um, the reason might be because the stone is a non-calcium stone. Okay, next. Okay, so the next modality CT abdomen, non-contrasted. Okay, CT abdomen is the best imaging modality, and it is the gold standard for urolithiasis, because it can detect the stone and also detect hydronephrosis. And also based on the CT finding, we can look at the appearance, the density of the stone, and the location of the stone. And these features may suggest the composition of the stones. Usually, uric acid, cystine, and struvite stone can be distinguished from the calcium oxalate stone. However, CT abdomen is not widely available. Okay, next. Okay, previously, before CT, the gold standard is IV intravenous urogram, IVP. However, nowadays, it is not commonly done because it is largely replaced with CT scan. It is a radiographic study of the renal parenchyma, pelvic system, ureters, and the urinary bladder. We administer contrast to the patient through the intravenous, and then after that, serial X-ray is being taken. Okay, next. Okay, this is example of the IVU. Okay, the first photo is the first photo, the initial of the investigation. The second photo is 10 minutes after administration of the contrast, and the third photo is 15 minutes. Okay, initially we can see that there is no evidence of calculus. However, after 10 minutes, we can see at the right side of the kidney there is dilatation of the proximal there is a dilatation of the pelvic system. And after 15 minutes, the findings are persistent, and we can also see there's a filling defect at the L3, L4 level. Okay, next. Okay, these are more example of the imaging. Okay, next. Okay, other than imaging, we also do lab investigation and metabolic evaluation in patient that we suspect having urolithiasis. Among the common investigation that, however, these investigation need to be tailored with the patient history and physical examination. Okay, among the most common investigation is full blood count. Based on this full blood count, we want to know if patient is um, having infection. We can look at the erythrocyte level. We can also look at the C-reactive protein to see the if patient is having infection. And also we can also look at the renal profile, which we want to check if there is any effect of the stone on the renal function. And also we can also check the serum uric acid, because patient with high serum uric acid might have uric acid stone. And also we can do urine analysis uh, to check for microscopic blood, and we can also do urine culture to investigate the possible organism and do early intervention. Okay, next. However, in two special group, um, first group is pregnant lady. We cannot do CT scan and X-ray because of the radiation exposure. So the main diagnostic tools in pregnant lady is ultrasound KUB. However, there's certain study that says that low dose CT scan can also be done in pregnant lady in second and third trimester to diagnose stone. Other alternative investigation is MRI. Okay, next. Okay, the second special group is child. In children, uh, there is high risk of recurrence if patient have stone. So we need to do a more detailed investigation. So the most common problem is vesico-urethral reflux, uh, uretropelvic junction obstruction, and neurogenic bladder. And these problems usually cause precipitate in stone formation. And in child, usually they are uncooperative and they are more sensitive to ionizing radiation. Usually, we do KUB ultrasound, and also we can do low dose non-contrast CT to diagnose stone. And also we can do a magnetic resonance MRI to 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 look at the urinary system. However, bear in mind that MRI cannot diagnose stone. Okay, I think that's all from me. Thank you. Any question?
I quite surprised what you say. MRI cannot diagnose stone. What you mean by that?
MRI cannot see the stone. Kan?
Are you sure?
Oh, boleh. I'm sorry, Mister.
You dah okay, okay. I've lupa pula. You specialize posting next
Dah.
Dah ha. So MRI is same like CT scan. They can give a contrast. Okay. First thing, you can have one. You need to understand the imaging concept. One, actually, patient have solid organ. For example, kidney, liver, solid organ. You can straight away see the structure with a CT scan, MRI. That's one. In case of stone, you may not able to see the stone with certain imaging, but with contrast, you will see the stone with a form of filling defect. So if you see there is filling defect inside the ureter from contrasted MRI T2, let's say T2 imaging, so you can see there is stone. Uh, that's why when you read, you must be careful, because if you read the MRI cannot see the stone. It means that the first scan, which is plain, you're not able to see the stone. But same thing like your initial presentation on IVU. IVU in radiolucent stone, you're not able to see the stone because IVU actually the normal X-ray. After they give a contrast, the contrast will be excreted by the kidney, and later on you can see the contrast inside the ureter. Whatever filling defect in the ureter, most likely the stone, especially meniscus sign, all that. So that's how the imaging works. So if generally you say MRI cannot see the stone, it's wrong. The plain MRI cannot see the stone, cannot diagnose the stone. But once they give a contrast, same like IVU, you can see the filling defect, or you can see the contrast filling defect. You can say that this most likely a stone. Okay. One thing I doesn't like your presentation. You go to imaging first, which is not in line of management. When you manage your patient in A&E, like say the patient come with urethric colic as your colleague present about the symptom just now, what the first thing you need to do is urine. When you send urine, there is blood in urine, clinical presentation of classical colic, most likely stone can be 80 to 90% most of time. That's one. Two, you need to go for whether patient is presented with complicated stone disease or just biliary, urethric colic, just pain. So there are three important things in managing renal stone or urinary tract stone. One is pain without other complication. Two is renal impairment, especially acute renal failure. The previous renal function normal, sudden jump after patient have pain. Three is infection. Patient have fever, patient have leukocyte and nitrate positive in urine, renal function positive. So it changed your management in terms of imaging. If the patient came with just pain, the primary treatment is just painkiller, and we go for CTU later as an elective. That's why I said I doesn't like Yansu straight away imaging. It's like a machine. You send, okay, send patient for CT scan. It's not communicating between the sign, symptom, simple investigation or bedside procedure with imaging. So if the patient came with fever, total white high, urine nitrate positive, you think patient have infection going on with a urethric stone, you might change your imaging from basic principle of plain imaging to intervention imaging. What I mean intervention imaging, you can do retrograde pyelogram. I mean, you do RPG, retrograde pyelogram from below, or you can do APG, antegrade pyelogram through the nephrostomy without CT scan. Because we know that patient have sepsis, you need to drain the pus or the collection of infective material inside the kidney. So CT scan, we can skip because we can do retrograde pyelogram, diagnose the patient to have urethric stone through the retrograde pyelogram. In the same time, we intervene by putting a stent to bypass the obstruction. So that's why the flow of management is markedly changed when you have different result in the urine result and WBC or full blood count result. So that's important to review all the simple investigation and plan for imaging. You don't just send patient come with colic, send for full body scan or for CT scan to see any stone. No, we go step by step in terms of management. And some patient we faster the management with urgent CT or urgent MRI, because we do MRI in patient with pregnant. If patient pregnant, we need a diagnostic tool to get whether patient have stone or other disease. We can do MRI, but not CT scan. So that's why interpreting and review the full blood count result and urine result as well as renal function result is important before your plan for imaging. Okay, that's my comment. Others, I think, have been explained with your colleague, by your colleague. Any other question?
Mr. I have question.
Mm-hmm.
So, in between renal ultrasonography and also the kidney ureter bladder radiography, which one is the most preferable imaging for the stones?
Okay, the same thing as I mentioned. Your managing patient is based on how they present. If let's say patient presented with fever, urine culture or urine FME positive, renal punch positive, you think the patient have pyelonephritis or even pyonephrosis, you go for urgent ultrasound, because ultrasound will show you the floating material inside the renal pelvis, which suggests of pyonephrosis. So you need to stand the patient to prevent patient go to sepsis. But if patient come with renal colic, no fever, renal punch negative, urine only present on RBC, you can do ultrasound. Sorry, you can do a KUB X-ray first. No need to do even ultrasound. After do KUB X-ray, you can see the stone. You can plan for CTU straight away. So that how it change your management. In general, in clinical practice, most of the hospital, when patient come, because KUB X-ray is standard, it can be ordered by most of the doctors. So not need a surgical team or urology team to order the special imaging, like the imaging like KUB X-ray. So as a screening tools, KUB X-ray usually done by family medicine family medicine is outpatient by A&E doctors as a screening, because the pickup rate is very high, up to 80 to 90%. So you say which is better, in private they come with urinating colic, urine FME shows RBC, they go straight with CTU. So because CTU will overrule all those two imaging. So in practical, we are based on how the patient presented. So in general, KUB X-ray still very good tools as screening imaging.
Okay, thank you, Mr.
Okay. Okay, any other question? If no further question, we can go for last presenter for another two. Orang lagi kan?
Okay, so my name is Mas Hafizul and I will proceed with the management part. So next slide. So the principle of management is by first one, effective pain control by giving NSAIDs as the first choice, or alternatively we can give paracetamol if depending on the cardiovascular risk of the patient. Sometimes patient with NYHA 2 to class 2 to 4 is contraindicated to use diclofenac, so we give paracetamol. Either you can give opioids. Second one is treatment of any suspected UTI or obstruction. The third one is treat underlying causes. The fourth one is the modification of the lifestyle. And also the last one is the treatment choice, which can be either medical or surgical or active stone removal. So next slide. So sometimes patient comes with a complicated stone with evidence of sepsis. So in this situation, we consider it as a urological emergency. So in this patient, we need to decompress the urinary system by giving a stent or percutaneous nephrostomy. And then we start the antibiotic immediately. And only then, until the infection is cleared, we can proceed with the definitive treatment by removing the calculi. Next slide. So with respect to the stone of the patient. For example, a gout patient, we give allopurinol to reduce the uric acid in the body. For patient with hyperparathyroidism, if indicated, we do parathyroidectomy. For patient with hypercalciuria due to dietary intake, so this can be managed by reducing the milk, cheese, butter, pastry intake. The next one is idiopathic hypercalciuria. So in this patient, we give thiazide or by alkalinizing the urine. The last one is the oxaluria. So in this case, it can be either primary or secondary. So primary is basically a hereditary, a genetic predisposition in which sometimes the liver do not produce the enough oxalate oxidase to metabolize the oxalate. So there is a high amount of oxalate in the body. So in this way, we cannot modify, but the modifiable one, which is the secondary cause, is basically due to diet. So in this case, we prescribe the patient to reduce the ingestion of tea, particularly the black tea, coffee, or chocolate. Next one. So this is the modification of the lifestyle. The first is by increasing the fluid intake. Second, by increasing the intake of fiber, reduce intake of protein-rich food, reduce intake of oxalate-rich food, reduce intake of sodium-rich food, and also reduce intake of sugar. Next slide. So the medical treatment, if is indicated, if active stone of removal is not indicated for this kind of patient. So most small urinary calculi will pass spontaneously and can be treated conservatively. So the indication is the stone with the size of less than 5 mm, but unless it causes persistent symptoms. So medical expulsive therapy, it helps in passage of stone with fewer colic episodes. So in this intervention, we give alpha blocker such as tamsulosin, calcium channel blocker such as nifedipine, and phosphodiesterase type 5 inhibitor such as tadalafil. But this medication is not without complications. So such as the alpha blocker, we need to anticipate if the patient have hypotension. So if analgesia cannot be achieved medically, drainage using stenting, percutaneous nephrostomy, or stone removal is indicated. So next one. So this is the active calcular removal. So this is indicated in if there is obstruction of urinary flow, infection, persistent, recurrent, or severe pain, also called asymptomatic calculi. Calculi likely to cause future obstruction or infection. Small metabolic calculi that is likely to grow rapidly in size, and patient with a solitary kidney. Next slide. So this is the methods of calculi removal. Next slide. So the first one is the extracorporeal shock wave lithotripsy, ESWL. So basically, it uses high energy of shock wave to break down the calculi into small crystals so that it can pass through the urine. So the wave frequency that is optimum is between 1.0 to 1.5 Hz, and it is used for renal and upper ureter calculi. It is a non-invasive technique, but some stones is resistant from this kind of intervention, such as the calcium oxalate monohydrate, calcium phosphate, and cysteine, because these kind of stones have a very high density, which is more than 1,000 Hounsfield unit. Hounsfield unit is you measure it by using CT scan. Next one. Percutaneous nephrolithotomy. So this is a minimally invasive procedure to remove calculi from the kidney by a small puncture wound through the skin. So this is done for renal calculi that is incapable for ESWL to disintegrate. But the contraindications include patient with untreated urinary tract infection, tumor in the presumptive access tract area, potential malignant kidney tumor, pregnant woman, and also untreated bleeding diathesis. Next one. So this is a ureteroscopy, lithotripsy. It is for removal of both renal and urethral calculi. So the calculi can be extracted by endoscopic forceps or basket. So it also used for stent placement to assist the calculi removal. The risk of this intervention is urosepsis, strictures, urethral injury, and also urinary tract infection. Next one. So this is a percutaneous vesicolithotripsy to remove the vesical calculi, the bladder calculi only. So this is a traumatic endoscopic approach in which we do a percutaneous suprapubic puncture and we have a direct visualization of the calculi. And then the calculi can be extracted by vacuuming it. Next one. So this is an open surgery, which is pyelolithotomy, ureterolithotomy, and also cystolithotomy. So this is indicated when the previous intervention or techniques have failed. Also, it is used in to correct the anatomical abnormalities and also for a very large stagnant calculi. Next. So this is a algorithm for managing ureteric stone extracted from the EAU guideline 2019. So for a ureteral stone, we divide it by locating, is it a proximal ureteral stone or distal ureteral stone? So for proximal ureteral stone, measuring more than 10 mm, the option include URS, ureteroscopy, and as shockwave lithotripsy. For size less than 10 mm, we give SWL or URS. For a distal ureteral stone measuring more than 10 mm, we give URS and also SWL. For less than 10 mm, we give either SWL or URS. Next slide. So this is for renal stone. So it also determined by the location of the kidney stone also. So for the kidney stone, for more than 20 mm, we give PNL and also RIRS or SWL. For stone measured between 10 to 20 mm, we give SWL or endourology. Less than 10 mm, we give SWL or RIS and also PNL. For the lower pole stone, measuring between 10 to 20 mm, there is the factors that make it unfavorable. So if it is not favorable, we give SWL or endourology. If favorable, we give endourology and also SWL. I think that's all for the management part.
Okay, any question? Okay, first I think it's really flexible in terms of management. As I mentioned during investigation just now, it's much on how patient presented. For me, in my management, I actually divide into two. One actually simple urethric or renal colic, who presented with colic or pain. 2 is complicated or complication, patient with complication. Because patient presented with pain, how big the stone, where the stone, it's not really matter. What you need to control is just control the pain and get to the detailed anatomy of the urinary tract as well as size of stone and location of stone. So from there you can plan your management. You have plenty of time. You don't have to rush because the stone, as your friend mentioned, infected stone going to be faster growth. No, it's just theory. That one you can just theory is when you correct the patient factor, ask the patient to take a lot of fluids, improve, put it on citrate, the stone enlargement will be slowing down. So that's why if no complication, what I do, I will go for complete workup before discuss with patient regarding plan. That's one. 2, a patient with complication. 1, patient with infection. 2, patient with obstructive uropathy. What mean obstructive uropathy? Patient have stone or any other disease which cause obstruction of urinary tract with change in renal function. So sometimes mild obstruction, no change in renal function, we still able to buy time, manage conservatively until we get the whole imaging about the stone disease. So in complicated case or complicate case with complication, we can bypass the obstruction, especially in ureter, or sometimes the bladder stone also can block the urethra. So in bladder stone, you just put in CBD and get to, after that patient will recover from obstructive uropathy, but you cannot remove CBD until you remove the bladder stone. Once you remove the CBD without preparing to remove the bladder stone will going to the bladder neck and obstructed it again. That's one. 2, in the urethric or renal stone, especially in the pelvic renal stone, sometimes it cause obstruction and cause infection. So in these 2 type of case, you can put in stent or you can put in nephrostomy. Either one. We prefer stent because patient have a good quality of life with stent. Because stenting will don't have any adhered medical device around her or his body. In nephrostomy, they need to carry the bag, which not comfortable and reduce the quality of life for the patient. Sometimes patient difficult to start their back to their work as early as possible. So that's how in clinical management of stone. So detail have been presented by your colleague, where the stone in the ureter, basically URS, stone in the kidney, it can be have 2 options. One is retrograde intrarenal surgery, RIRS, or PCNL. As your friend shows the slides that 2 cm stone in the kidney, you can do RIRS and PCNL, or PCNL. But be careful that a big stone, RIRS alone usually, single RIRS usually not adequate. So usually if patient choose to do RIRS, it should take a serial RIRS, 2 or 3 sessions. A good thing about RIRS, there are no wound or no puncture wound at all. Just before that, the slide before. Another one. Sorry. The flexible scope just now. This one. This is actually RIRS. But this picture showing the old pictures, they're using a basket. Nowadays, we use a laser as what we call energy source to break the stone. So we don't use any more basket because while pulling out the stone with basket, it can cause a urethric trauma. Okay, so now we use a laser, we vaporize the stone, so the fragment will come out with urine without a need to pull out the stone with basket like this. This actually flexible URS or RIRS because this scope can go up to all the calyx of the inside the kidney. Right? Or sometimes some books they call a flexible URS. So still URS but using a flexible scope. That's how actually summary of stone management. The last one I will talk about open surgery. As your friend mentioned, the open surgery if a huge stat horn or open surgery can be done to corrective the stone. I think partly true, but not all. Actually, for the large stat horn, same like RIRS, we can do serial PCNL. We can do PCNL this month, remove the lower pole and pelvic stone. For next month, we can do another repeat PCNL to remove upper pole and mid pole stone. That's how we do. Nowadays, pylorithectomy or nephrolithectomy for the stat horn calculi have been largely replaced by PCNL. However, open vesicolithectomy, cystolithectomy dia guna. Open vesicolithectomy is still a gold standard for large bladder stone more than 4 cm. It's widely practiced. We cannot crush the stone because stone is too big to be crushed. It takes 3-4 hours or even more if a stone big inside the bladder. So we do open vesicolithectomy. You are using a cystolithectomy. I think the same thing. Okay, that's one still gold standard. Another one is still gold standard is urethrolytotomy. Urethrolytotomy is still gold standard, although you have URS, but in we call large impacted urethric stone, about 2 cm. When you do URS in this type of cases, the urethra can be perforated, and the perforation can be large and not easily to what we call heal by itself. So the best option for large impacted urethric stone is open urethrolytotomy. So that's two still gold standard open surgery. One is open vesicolitotomy, two is urethrolytotomy for large urethric stone. Others is have been replaced by an intervention or endourology surgery. Okay, I think that's all from me. Any other question?
Sorry, mister, can you repeat the size of the ureteric stone just now?
Urethric stone is 2 cm, bladder stone is 4 cm.
Okay, thank you, mister.
Okay. One more open surgery sometimes we use for stone disease is a nephrectomy. If the stone have been obstructed for long duration and the kidney have become non-functioning, we need to do elective nephrectomy to remove the kidney, because if you left there, the kidney can be infected and patient can sepsis because of infected kidney. So the as I mentioned, urethrolytotomy, open vesicolitotomy, and also nephrectomy. Okay, any other question? Any other question? Sorry, I actually not really aware about your change in timetable. I thought your posting is same like previously. Now, how long you're posting?
5 week online teaching and 3 weeks face to face.
No, I think it will be changed, right? Now, no more face to face, right? After MCO. Okay.
Nanti balik ke ada face to face.
Okay, I understand. Now they bring the face to face later next year, something like that.
And
Okay. Never mind. Sorry. I thought you still have 3 weeks ahead, so we can do somewhere next week or next 2 weeks. Anyway, Alhamdulillah, it's okay. I've been done. Any question, you can just email or whatever. I think I'm always available. Once you come back to the hospital, if you think you need a teaching or urology topic, most of time I will be there in clinic on Tuesday. My clinic day on Tuesday. You can take turn to come to the clinic after MCO. I think hopefully it's okay. Okay, if no more question, we can stop here. See you later in face-to-face session next year. I think maybe in January somewhere. Okay, Assalamualaikum warahmatullahi taala wabarakatuh.
Waalaikumsalam.